Hello students, in this lecture I shall talk about the pathology of prostate. Many of the figures and diagrams that I have used in this lecture has been taken from the Robbins and Cotran Pathologic Basis of Disease 9th edition. Let us look at the normal anatomy of prostate. As you know, the prostate is an organ which lies beneath the urinary bladder, and the urethra passes through the prostate. The prostate is divided into different parts. The area which is adjacent to the urethra is known as the central zone. And adjacent to the central zone, you have another zone which is known as the transition zone. The area which is away from the urethra is known as the peripheral zone. Most of the benign diseases like the benign hyperplasia of prostate arise within the central zone and the transition zone. Hence they lead to compression of the urethra and the symptoms related to it. Whereas the carcinomas, they tend to arise in the peripheral zone. So they do not cause compression in the early part of their disease. This picture shows you the normal histology of prostate gland. You might be knowing that prostate is also called as a fibromusculoglandular organ. So there are three components. The prostate contains glands, the muscle tissue which supports the gland, and the fibrous tissue, hence the name fibromusculoglandular. If you look carefully, the glands have a double layer epithelium. There are two rows of nuclei representing the two layers of cells. The cells which are towards the lumen, known as the luminal cells, they are the epithelial cells, whereas the cells which are towards the base or away from the lumen or abluminal cells are known as the basal cells. The importance of these basal cells is that in most of the benign lesions you will see the presence of basal cells, whereas in carcinomas or cancers there is a loss of the outer basal cell. So the glands become monolayered. Let us discuss the most common pathology of prostate, that is the nodular hyperplasia of prostate, also known as the benign hyperplasia of prostate. Now don't go by the term benign. Benign sometimes students confuse as a benign tumor. But as the name suggests, this condition is not neoplasia. This is hyperplasia. Hyperplasia means there is increase in the number of cells, thereby leading to increase in the size of the organ. This should be distinguished from neoplasia, whereas neoplasia is a tumorous or neoplastic growth. So this is a hyperplasia, not neoplasia. Please keep that in mind. All this disease occurs beyond the age of 50 years. It is hardly ever seen in men below 50 years of age. The basic pathology is here. There is a nodular enlargement of the prostate, and mostly it affects the periurethral region or the transition zone, and hence it compresses upon the urethra, and the symptoms that you see in this disease are usually related to obstruction of this urethra. Let us have a look at the pathogenesis of this disease. The most important hormone, the testosterone, is derived from the testis, and it acts on the cells of the prostate. It acts on both the stromal cells as well as the epithelial cells. But there is a difference. The stromal cells contain an enzyme known as the 5-alpha reductase type 2 enzyme, which is not seen or not present in the epithelial cells. The type 2 enzyme is seen in the stromal cells, whereas type 1 enzyme is not seen in the prostate. It is seen outside the prostate in the peripheral fat and maybe the skin area. The function of this enzyme is converts the testosterone into dihydrotestosterone. This dihydrotestosterone then acts on the androgen receptors which are present on the nucleus of the cells. It induces the synthesis of growth factors. The most important growth factors that are elaborated by the effect of dihydrotestosterone are the fibroblast growth factor and the transforming growth factor beta. Both these growth factors, they lead to mitosis and proliferation of the stromal cells. However, the same dihydrotestosterone has a paracrine effect also. It affects the adjacent epithelial cells also and induces the production of similar growth factors. These growth factors, that is the fibroblast growth factor and transforming growth factor beta, acts on the epithelial cell, but they do not cause cell proliferation. Rather, they lead to decreased death of the epithelial cells. Hence, the epithelial cell do not die and accumulate, whereas the stromal cells proliferate, divide and increase in number. So finally, what you get in prostate under the influence of testosterone is that there is proliferation of the stromal cells and accumulation of the epithelial cells. That gives rise to increase in number of cells and hyperplasia of the prostate. Let us have a look at the gross features. What happens to the prostate grossly? The prostate usually enlarges to a size of 60 to 100 gram. Normal size of prostate is about 20 grams. This pathology arises in the transition zone that leads to hypertrophy of the median lobe. As you can see in this picture, this is a transverse section through the enlarged prostate. Here you can see the urethra which has been compressed by the growth of multiple nodules. Hence the name nodular hyperplasia of prostate. Some nodules have more epithelial component than stromal. Like this nodule has got more stromal component, whereas this nodule has got more epithelial component. Epithelial component will form glands and cysts, hence it will give a spongy and soft yellow appearance to the nodule, whereas stromal cells do not form cysts or glands, so the nodules are usually hard and non-cystic. If you see the prostate under microscope, in this case you will find that the number of epithelial cells and glands have increased tremendously. So is the stroma. As you can see in this picture, the glands are now large, they are very irregular and cystically dilated. If you see, the epithelium is thrown into infoldings like this, and at places they are thrown into outpouchings. So there is epithelial infolding and outpouching. This basically happens because the number of cells exceeds the area of the gland. Hence, to accommodate the increased number of cells, the gland has to throw infoldings to support the epithelial cells. In addition, you can see that there are secretions which has become lamellated within the glandular lumen. The glands have very little stroma in between. This is what is known as a back-to-back arrangement. The double layering of the epithelium is retained. As I already mentioned, that the epithelial and basal layers are the two layers, cell layers of the normal gland, and the double layering is maintained in benign condition, whereas it is lost, or the basal cells are lost in malignant diseases. Since this is a benign condition, you will get a double layered epithelium. There will be both luminal and basal type of epithelium. So in summary, you get enlarged dilated cystic glands with irregular lumen, outpouchings, inpouchings, back-to-back arrangement, prostatic secretions, also known as corpora, amylasia, and increase in the amount of stroma. Now you can predict the clinical features of this condition. As I already mentioned, the clinical features are related to obstruction of the urethra by the nodules. So in early stages there may not be any symptom, but when the nodules enlarge in size, the symptom progressively increase. So what are the symptoms that you expect? There would be bladder hypertrophy, because the bladder has to now push the urine through an obstructed system. So there will be hypertrophy of the muscle of the bladder. There can be total occlusion of the urethra leading to urinary retention. Patient usually complain of incomplete evacuation of the urine, so that they have to go for urination repeatedly. Obstruction and retention of urine may lead to growth of bacteria and infections. There will be increased number of urination, also known as frequency. Patients also suffer from urgency. There is an urgent requirement or feeling of urination. The patient goes to urine, but the flow is very scanty, and once the flow starts, the patient are usually unable to control the flow. They cannot stop it, hence this leads to dribbling. There is difficulty in urination. Patients suffer from dysuria, and due to incomplete evacuation and retention, the patient may go for urination multiple times, and that leads to nocturia. Nocturia means increased frequency of urination in the night time. This should not be confused with the nocturia that you see in diabetes mellitus. So that was about nodular hyperplasia prostate. Next topic that I shall talk about is adenocarcinoma prostate. You can pause the video and see it later, or else you can continue. The adenocarcinoma, that means a malignant epithelial tumor forming gland-like structures, is known as adenocarcinoma. That is the most common type of cancer that you will see in prostate. This cancer is more common in the Western countries and very uncommon in the Asians. Usually it affects patient above 50 years of age. It's very uncommon in less than 50 years. Lot of etiological factors have been implicated, but none have been proven beyond doubt. As in any other carcinoma of the body, you will see that the etiology, the list will contain the diet, hormonal effect, and genetic effects. Increased intake of fats and red meat, charred red meat, is thought to increase the chances of getting a prostate cancer, whereas taking tomato, vitamin D and soy products may actually reduce the incidence. Androgens, increased androgens are implicated in the development of the prostate cancer. Numerous genetic factors have been identified, the most important being the BRCA2 and HOXB13 mutations. It has been seen that patients or persons who are first degree or second degree relatives of patients of prostate cancer have an increased risk of development of prostate cancer. Minor percentage of cases has been seen to harbor TPRSS2 ETS gene rearrangements. Many other oncogenes and tumor suppressor genes mutation and epigenetic changes have been identified that include the MYC gene, P10, P53 and the GSTP1 gene. In addition, the retinoblastoma gene, the CDK2NA, which are all cell cycle regulators, the MLH1 and MSH2, which regulate the microsatellite instability, and the APC gene mutations have been implicated in adenocarcinoma of the prostate. The adenocarcinoma also has got a precursor lesion. The precursor lesion in prostate is called as prostatic intraepithelial neoplasia or PIN. If you look at this is a normal histology and this is PIN or prostatic intraepithelial neoplasia. PIN is recognized by the fact that the number of cells in the epithelium increase, that is known as multilayering of the epithelial cells. The nuclei start showing atypia. If you compare the nuclei in this picture and in this picture, we will realize that the nuclei here are enlarged and they show prominence of nucleoli. That's the hallmark of PIN, prominence of nucleoli. And these glands usually do not have the corpora amylaceae or concentrated lamellated secretions that you see in normal prostatic glands. You see corpora amylaceae also in benign prostatic hyperplasia, but you don't see them in prostatic intraepithelial neoplasia or cancers. The PIN is further divided into low grade and high grade. The PIN can undergo malignant change and become adenocarcinoma. The adenocarcinoma is the most common cancer of the prostate. As you can see in these pictures, adenocarcinoma is characterized by presence of malignant gland-like structures which infiltrate into the normal structures. As you can see here, there are some normal prostatic glands are there, and in between the glands the malignant glands are infiltrating. So invasive acinar adenocarcinoma. In addition, in the high power, you can see this is the normal epithelium. You can see the difference between this and this. This shows you nuclear atypia, that is nuclear enlargement, hyperchromasia, prominence of nucleoli and mitosis. And very importantly, these glands, they do not have the normal basal cell layer. The basal cell layer is always present in the benign glands. That is how we distinguish between benign and malignant glands in prostate. Prostate cancers are notorious for perineural invasion. As you can see in this picture, the nerve bundles, nerve fibers, around the nerve fibers, the malignant gland, they infiltrate. This phenomenon is known as perineural invasion. This leads to a lot of pain. There are other tumors in the body also which show a lot of perineural invasion. One of them is the adenoid cystic carcinoma of the salivary gland, and another is a cholangiocarcinoma of the liver. Like any other cancer, the prostate cancer is also graded and staged. The grading, a system of grade scoring is used known as the Gleason's score. If you look at this picture, you will see that if the glands, this is the malignant glands of the adenocarcinoma, if they are very tightly packed and their boundary is very defined, then the score given is 1. If there is looseness of the gland and the boundaries become less defined or ill defined, then score is 2. Similarly, if the looseness goes on increasing and the boundaries becomes more and more irregular and indistinct, the score increases from 3 to 4 and 5. Now this may happen that in the same cancer you may have some area showing score 1 and some area showing score 3. In such a situation you have to add up the scores. So if a tumor is showing score 2 in some areas and score 4 in some areas, then we will add it up and the final score will be 6. So the primary score and the secondary score both are added to get the final score, and based on that the prognosis of the patient depends. If the final Gleason score is 6 or less, then the tumor is said to be well differentiated. That means it's a less aggressive tumor and it is expected to grow slowly. If the score is 7, the final score, which can be either 3 plus 4, 4 plus 3, 5 plus 2 or 2 plus 5, anyways it can become 7, then the tumor tissue is said to be moderately differentiated and it is moderately aggressive, may not spread quickly. But if the score is 8 to 10, then the tumor is said to be poorly differentiated. It is likely to grow very fast and spread very fast and kill the patient rapidly. So this is the Gleason scoring system. Many modifications of this system has been made. There are some modification recently. If you are interested, you can go and look at the modifications. The staging is done according to the TNM staging system. T stands for tumor, node stands for the nodal status, and M stands for the status of metastasis, right? A tumor is said to be T1 or T2 if the tumor is confined to the prostate. That means the tumor is still within the prostate, it has not invaded beyond the prostate. A tumor is said to be T3 if there is local extraprostatic extension, and it is said to be T4 if there is invasion of adjacent organs. If it has gone beyond the pelvis, gone to liver, lung and lymph nodes, then you will call it M1. If there is no metastasis, you will call it M0. If node is involved, it is known as N1, and if node is not involved, then it is designated as N0. So for any given tumor, the T, N and M are identified and then final staging is done. A few words about the prostate specific antigen. This is a very important substance. It is measured in the serum as serum PSA levels. The normal value being 4 nanogram per milliliter. Some authors may consider up to 2.5 nanogram per milliliter as normal, but mostly 4 nanogram per ml is considered to be a normal Increase in PSA level above 10 is highly suggestive of adenocarcinoma of the prostate. Anything which is between 4 and 10 can be due to acute inflammation of prostate, benign hyperplasia of prostate, instrumentation of the prostate, or can be due to carcinoma. So 4 to 10 value are considered borderline values. It can be due to benign or due to malignant, but if it's more than 10, it is very likely that the patient is having a adenocarcinoma. Rate of change of prostate specific antigen is also noted. If it is more than 0.75 nanogram per ml per year, then it is considered to be highly suggestive of a adenocarcinoma. Recently, another molecule, the PCA3, which is basically a RNA fragment, is seen in the urine of patients of prostate cancer. It is very specific and a test is available for detection. Hence, this can also be used as a biomarker for prostate cancer. Treatment of prostate cancer is usually either by surgery or by radiation therapy or hormonal therapy. The radiation therapy can be brachytherapy, which means radioactive tablets are put inside the prostate, which provide radiation from inside, or it can be an external beam radiation therapy. Hormone therapy is employed in many cases that usually targets at deprivation of androgen, because as we have seen in etiology, androgen is a very important cause of prostate cancer. Now, androgen deprivation can be done either by orchidectomy, or that is removal of testes. Both the testes of the patient is removed so that no more testosterone is produced in the patient. This is known as surgical orchidectomy. Or the patient is given luteinizing hormone releasing hormone analogues that lead to decrease in testosterone production from the testes. This is known as pharmacologic orchidectomy. So any of these strategies can be employed according to the stage and grade of the disease. This brings us to the end of discussion on the disease of prostate. Let me give you a recapitulation. Here in this lecture, we learnt about the normal anatomy of prostate, which is depicted in this picture. The prostate has a central zone and a peripheral zone, and most of the benign lesions arise from the central or zone or the transition zone, whereas carcinomas arise from the peripheral zone. Normal prostate has got glands and smooth muscle and fibrostroma, and the glands have a double layer of inner epithelial and outer basal cells. Benign hyperplasia of prostate is not a tumor, it's a hyperplasia where there is an increase in the number of stromal cells and decrease in depth of the epithelial cells, leading to their abnormal accumulation. The most important hormone that plays role is the testosterone, which releases fibroblastic growth factor and transforming growth factor beta, which acts as oncogenes. Grossly, you see multiple nodules which compress the urethra and lead to different symptoms. Microscopically, you see enlarged, cystically dilated, infolded and outpouching of the glands, along with stromal hyperplasia and corpora amylaceae. The clinical features are mostly related to compression on the urethra. Adenocarcinoma prostate, various etiological factors are known, but none have been proven. The precursor lesion is known as the prostatic intraepithelial neoplasia, which can be high grade or low grade. Adenocarcinoma is usually the SNR type, and the hallmark feature is lack of basal cells and infiltrating acinar structures with nuclear atypia. Perineural invasion is another characteristic feature. For grading of prostatic adenocarcinoma, Gleason scoring is used. A score of 6 or less is called as well differentiated carcinomas, whereas a score of 8 or more is known to be a poorly differentiated and aggressive carcinomas. The TNM staging system is used for staging of prostate, and based on the different type of stages, the patients are treated either by surgery or radiation therapy or hormone therapy. Hormone therapy includes androgen deprivation either surgically or pharmacologically. Prostate specific antigen of the serum is a good marker for cancer detection of prostate. Another new marker is urine PCA3. That's all. I hope you have understood most of the lecture. Thanks for hearing.